Our next speaker is joining us all the way from Seattle, Washington, Dr. David Chang. Dr. Chang is currently on a sabbatical. However, he was formerly the medical director of the Polyclinic Sleep Medicine Center in Seattle. He will be speaking on non-pharmaceutical management of insomnia. Dr. Chang completed his medical degree at the Indiana University School of Medicine and is board certified in sleep medicine. He also enjoys traveling internationally with his family and has the hope of visiting Antarctica one day. Well, welcome to Oklahoma. We are not Antarctica. Please join me in welcoming Dr. David Chang.
Thank you so much for that generous introduction. I'd like to thank the organizers, the Osteopathic Founders Foundation, and St. Francis for hosting this talk. Thank you. And inviting me to be with you this morning. I'm actually a primary care doctor at heart who happens to be a sleep doctor. I actually did primary care for about 10 years before I entered sleep medicine. Interestingly, for me, sleep is my passion both personally and professionally, okay? I am going to talk about general principles about insomnia today, but not get into specific medications. So with a show of hands, how many have had insomnia symptoms in the last 6 months, either yourself or a loved one? Raising your hands. Good number of people, right? So my talk is titled Non-Pharmacologic Management of Insomnia. And let me grab this advancer here. So I have no conflicts of interest for this talk this morning. The learning objectives is defining insomnia, understanding the pathophysiology of insomnia, and how to incorporate cognitive behavioral therapy into clinical practice. The reality is, for a 10 to 15 minute visit, it's going to be hard to go through all that I'm going to be talking about this morning, okay? And I hope to have very practical tips for all of you for Monday morning clinic. So let's start. What is sleep? Now, you and I have been doing this since the day we were born, and yet we spend a third of our lives doing something that we're not aware of doing. Kind of remarkable if you think about it. It's a transition from wakefulness to a state of unconsciousness that's reversible. Now that's important to keep in mind. We're not talking about coma, anesthesia, or stupor. Also, we know that it's a periodic state where you are unaware of your surroundings. And there's no body movement usually during this state of sleep. It's essential for optimal health. When we were in training and sleep deprived, we felt the consequence of being sleep deprived. It facilitates recovery, rejuvenation, and even memory consolidation. Our body undergoes tissue growth and repair, right? And also bolsters the immune system. I remember back in college, after finals, I go home for break, and inevitably I would get sick, right? Because I was sleep deprived prior to finals. It also regulates hormone release, growth hormone, cortisol. In order to understand sleep, right, we break it down into two major categories. Non-REM sleep, which is broken down further into stage 1 through 3 sleep. Now, stage 4 sleep was actually removed from the nomenclature about, 5-10 years ago. So we only have 3 stages of sleep under non-REM, and then we have REM sleep. So let's talk about these different stages a little bit more. Stage 1 sleep is a transition from wakefulness to a state of unconsciousness, and during this state, our bodies have decreased respiration, heart rate, and muscle tone. Interestingly, if you get awoken out of this stage of sleep, you don't remember that you actually fell asleep. I have awkward moments with patients, right? They come in because their partner's accusing the patient of snoring, and then the partner says, "You're snoring," and the patient goes, "No, I'm not," because they fell asleep, but they were unaware they fell asleep. And so it makes for an awkward visit, as you can imagine. Stage 2 sleep is where we spend most of our nights sleeping. Approximately 50% of our night is spent in stage 2 sleep. On the EEG, we see K complexes and spindles. Stage 3 sleep is the deep sleep. So when we talk about deep sleep, it's stage 3 sleep. And we spent the first part of our night in stage 3 sleep, actually, where there's rejuvenation, and also that's where our body restores itself. Interestingly, if you awaken out of this stage of sleep, you're groggy and disoriented. I remember being a resident and being called by the nursing staff at 2 in the morning and being completely disoriented as the page was going off as I was in the call room. REM sleep, unlike non-REM sleep, does not have any stages. REM sleep is REM sleep. It's defined as the rapid eye movement that we typically see on a sleep study. There's also muscle paralysis. So when that muscle paralysis gets disengaged, we may see REM behavior disorder, right? Where patients will come in saying they're acting out their dream sequences. In those patients, we need to consider Parkinson's disease long-term. There is an association between REM behavior disorder and Parkinson's disease. There's also autonomic instability. The heart rate and respiration changes as we're dreaming. And interestingly, the EEG is very similar to when we're awake. So the EEG patterns in REM sleep is very similar to when we're awake. The only thing that prevents us from acting out the dream sequence is that paralysis. And we believe that memory consolidation occurs as well during this stage of sleep. So let's start with the clinical case. This is Sophia, a 30-year-old professor at the University of Oklahoma. She did obtain her PhD at OSU. She has difficulty falling asleep and staying asleep. This has been ongoing for approximately 10 months now. To add a little bit more color, she was finishing her dissertation about 10 months ago and starting the new position. She has no other sleep symptoms per her partner. She does go to bed early, between 8 and 9 p.m., but doesn't really fall asleep until midnight. She does admit to mind racing and getting frustrated when she's laying there. She does fall asleep. She wakes up approximately 2 to 3 times a night, and it takes her about 30 minutes to fall back to sleep. She does self-medicate with some over-the-counter sleep aids and alcohol on occasion, but really with mixed benefits. She does report a good night's sleep on vacation. Her bedroom is quiet and dark, and she's very eager to show you the Fitbit data. Interestingly, during the day, she does volunteer fatigue, and she's also a little bit concerned about her job performance with her teaching and research responsibilities. Interestingly also, after she started this new position, at 3 p.m., she's having coffee with her colleagues. And prior to going to bed, she's on her iPhone or on her work computer. No other significant past medical history, and her exam is normal. So with that as a backdrop, I'm going to delve into the physiology of sleep, okay? And we're going to come back to this case at the end of the talk. So this is a very busy slide, and I'm going to walk through this with you, okay? I'm going to talk about 2 processes, process S and process C. Process S on this graph, let's see if I get the pointer going here, is the blue line. On the y-axis over here, as we go up, is the increased pressure to sleep. And on the x-axis is time of day. So as we get our day going, so this morning when we woke up at 7, for example, we started building up this homeostatic sleep drive, this sleep pressure. And this pressure will continue to grow throughout the day. When we were on call, up for 36 hours, let's say, that pressure kept on building, which made us more drowsy. For someone with insomnia, if they take a nap, they pay off some of that sleep pressure, right? So by the time evening rolls around, that pressure is not as high as it could be, which is counterproductive. Circadian rhythm is something we all typically talk about, right? About sleep. So the circadian rhythm, depicted in red, kind of cycles through, a little bit of a sine wave. And the circadian rhythm is dictated by the suprachiasmatic nucleus in our brain. That's the timekeeper that all of us have in our brain. And that goes through a 24-hour cycle. This 24-hour cycle doesn't really want to change so much, right? It's called sleep inertia. So when we travel, right, so I'm a little bit jet lagged, right? It's a 2-hour difference between here and the West Coast. So last night, I did have a little bit of problem sleeping because I'm out of sync with my circadian rhythm. So you can imagine someone with shift work or jet lag can be adversely affected when they do these types of behaviors. The blue bars here represent the forbidden zone of sleep. Okay, what is this? Well, for the 90 minutes prior to your typical bedtime, it's going to be very challenging to fall asleep. Physiologically, it's very challenging for us to fall asleep. So therefore, if you have a patient on Monday morning that says, I'm taking my sleep aid, doc, but it's not working, you may want to ask them, what time are they taking that sleep aid? Because a lot of patients will take it at 8 p.m., 7 p.m., right? They want to give it time to kick in. But the reality is it's doing nothing for them. Because as it's kicking in, they're physiologically not going to be sleepy. Or another one is they go to bed early. Right? I want to maximize my time in bed because I'm not sleeping. Well, again, physiologically, it's going to be very challenging for them to fall asleep. The hypoarousal concept is a key mechanism in understanding insomnia. There's a heightened physiologic and psychological activity. This is due to chronic stress and anxiety. Also, there's activation of the sympathetic nervous system, right? The fight or flight response. Also, increased heart rate and respiration. All of this makes it more challenging to fall asleep. Also, the hypoarousal state increases or affects the hypothalamic pituitary adrenal axis. Cortisol, as we know, is secreted at its highest level in early morning hours, right? For giving us what we need to address what's going to hit us throughout the day. But in this hypoarousal state, the cortisol production gets out of whack. It tends to happen in the evening or in the late afternoon. And if the cortisol is being secreted at the wrong time, guess what? It's going to affect your ability to fall asleep. So this is the fun part, defining chronic insomnia, right? And this is based on the International Classification of Sleep Disorders. There's a dissatisfaction with quantity or quality of sleep. It's both sleep onset insomnia or sleep maintenance, and early morning awakenings with challenges falling back to sleep. The patient needs to have daytime consequences, and we're going to talk about that in a moment. It has to happen at least 3 days a week for at least 3 months. Also, the patient needs to have adequate opportunity to sleep, and it cannot be explained by another sleep issue or other medical condition. So what are some of the consequences of chronic insomnia? Well, it affects multiple domains, right? Cognition, memory, concentration, mood, motor function. You're at increased risk for accidents. Also, if we did a performance battery, you would have challenges with that. Social and occupational dysfunction, where patients are not able to function at work or in their personal lives. And also physical symptoms, right? We see that in our practice quite often. GI or headache, where patients are having somatic symptoms, but in parts because they're not getting good sleep. And of course, diagnosing insomnia is a challenge, right? There's not a single test to make this diagnosis. Interestingly, as it is a lot of things in medicine, a thorough physical exam and history is important. Maybe a sleep diary, right? To have a patient track in their records what they're doing throughout the week. It gives both them and you insight of what's transpiring. Now, a sleep study is indicated for those who may be at risk for another sleep disorder, right? Sleep apnea or restless legs, because restless legs can lead to periodic limb movement disorder, which can fragment one's sleep. As I tell my patients, it doesn't make sense to wire you up from head to toe, sleep in an uncomfortable bed when you're not sleeping already, right? You're not going to get much data. So a sleep test is not indicated typically for purely making the diagnosis of insomnia. This slide reminds me of the bidirectional relationship between insomnia and psychiatric disorders, right? Sometimes the insomnia itself precipitates bad mood. I mean, we've all been in a bad mood after we have a poor night of sleep, right? But in the same breath, the psychiatric disorder could lead to bad sleep. So if someone comes into you for insomnia symptoms, we need to keep top of mind the possibility of an underlying mood disorder. Insomnia is very prevalent in our society. Just with a show of hands, there's a good number of people with poor sleep. Based on definitions used and population studied, it's up to 50%. For chronic insomnia, it's about 10 to 15%. In my opinion, it's probably much higher, right, in terms of chronic insomnia. And again, the definition of chronic insomnia is over 3 months of symptoms. So the consequences, right, I think we see this daily in our practice. Poor clinical outcomes, right, increased risk for hypertension, diabetes, cardiovascular disease, fibromyalgia, right? Also, lower quality of life. Also, risk for accidents, as I said earlier, and the psychiatric issues. Also, they have a higher utilization of healthcare resources and lower work productivity. So I like this model, this 3-factor model, as we look at insomnia. And I'm going to go through each of these. The first is predisposing factors, right? Characteristics that make one more susceptible to insomnia. Precipitating factors and perpetuating. Now, I'll be honest with you, the next set of slides are a bit dry. So I will do my best to keep you engaged, short of dancing, okay? So what are predisposing factors, right? These are characteristics or traits that may make one susceptible to insomnia. Age. As we get older, the sleep architecture changes. Less deep sleep, less melatonin secretion, and our sleep just gets more fragmented. Women tend to have more issues with sleep in general relative to men. Lower socioeconomic status, increased financial stress. Maybe their sleep environment is not safe. Personality types, anxiety, people who worry a lot, people who are perfectionists. I just have to get it right. Also genetics, right? There's a genetic predisposition to having insomnia, but the exact gene sequences are still being evaluated. Delayed circadian rhythm can be an issue, right? So a typical patient will be second or third shift throughout their career. They get promoted, and guess what? Now they're on day shift. Well, these folks tend to have more problems with more conventional sleep times, right? Because genetically, they're night owls. And as we talked about earlier, the hyperarousal complex, the stress that affects the endocrine and cortisol production. So we just talked about predisposing factors. Now we're talking about precipitating factors. And there's a whole host of these that may lead to the insomnia. Acute short-term stress. I'll be honest, preparing for this talk, I've had a little bit of insomnia, right? That's normal. Or chronic, right? The last few years with the pandemic, I've seen a lot of insomnia cases in the last few years, right? Also, if you have an underlying medical condition, either medical or neurologic, major life events, both positive and negative, getting married, having a child, death of a loved one, divorce, loss of a job, all of these can affect your sleep. Stress, emotions, lifestyle adjustments, right? All a fact of life. But sometimes they get a little bit out of hand, which then affects the individual. Environmental factors, as I alluded to earlier, right? The temperature, light, noise can all affect how we sleep. I'd like to point out social jet lag. I'm not sure if you're familiar with this term, so I'll just review. So on a particular work week, we may have a certain schedule, right? And then on the weekends, we go to bed late by maybe 2 to 3 hours, get up late 2 to 3 hours. It's the weekend. And then on Sunday night, when we're asked to go to bed early to get up for Monday morning, we have a touch of insomnia. The example I use is if you got on a plane from the West Coast to New York on Friday night and flew back Sunday night, you probably have a little bit of jet lag, right? And this is no different, but it's socially induced. It's due to personal behaviors. Caffeine. It's the most used stimulant worldwide. It has a half-life of about 5.5 hours, but for certain individuals, it could be up to 9.5 hours. Nicotine is a stimulant, so something to keep in mind. Alcohol does help us relax, right? But as we metabolize the alcohol, it affects the brain because of simple sugars being produced. So actually, if you drink alcohol close to bedtime, it actually fragments your sleep more. And if you have sleep apnea, it worsens the sleep apnea and the snoring. I'll touch upon marijuana. It's not an illicit drug anymore in most states, right? There really isn't a lot of research on marijuana, to be honest with you. Right? It's been illegal for years. But we do know it may suppress REM sleep, right? And it definitely can help certain individuals sleep, but the research is really still out, needs to be done regarding whether there's harm associated with using marijuana. So perpetuating factors, right? So we talked about predisposing factors, precipitating factors, and now we're going to talk about perpetuating factors. These are factors that maintain or exacerbate the insomnia. It involves maladaptive thoughts and behaviors. Patients are more heightened or more awake when they go to bed, which is counterproductive, right? We want them to be relaxed, drowsy. It's almost like a Pavlovian response that they've gotten themselves into. And also negative beliefs and expectations. And also they have performance anxiety surrounding their sleep. Also they worry, they ruminate. They also feel like, oh my gosh, I'm exhausted, but as soon as they hit the bed, bing, they're wide awake. Sleep aids, whether prescribed or over the counter, can be helpful, right? But tolerance develops, dependence, or even rebound insomnia, where once they withdraw the medication, their insomnia gets worse. As I like to say, the brain is a very dynamic organ. It will circumvent the effectiveness of the sleep aid over time. It doesn't matter when, right? Days, weeks, months, maybe years. Patients may also have intrusive thoughts, right? They can't turn off their mind. And they also have what we call cognitive distortion, right? Unrealistic assessment of their sleep, where they catastrophize the fact that they didn't sleep last night. Their life is ruined because they didn't sleep. And at that moment, it's very serious for the patient, right? But it's not maybe not be realistic. And sometimes the precipitating factor can be perpetual. So my example is pain. Someone has postoperative pain, but the pain lingers a little bit, so the precipitating pain becomes a perpetual problem. And there's probably a bunch of others that you can think of. So I remember growing up outside of Philadelphia in South Jersey, and on the rabbit years on the TV set, I'm dating myself here, there would be about 6 TV stations. And then after the 11 o'clock news, 5 of them would play the national anthem and go to snow. Who remembers that, right? But look at us now. The amount of content we are exposed to is innumerable on our devices, right? I like this slide to remind me to share with you the importance of sunlight. So, to your left? Yes. So to your left, we see the sun. And there's actually a direct link from our eyeballs to the suprachiasmatic nucleus. That's through the retinohypothalamic tract. Right? So people can be blind, but still have perception of light. And that helps set the circadian rhythm. And with the suprachiasmatic nucleus, or the SCN, right, when it perceives light, it will tell the pineal gland not to secrete melatonin. Okay? And when darkness occurs, sorry about that, the melatonin is secreted. So one of the advice I give to my patients is to expose yourself to bright light first thing in the morning, sunlight. So I have a lot of older patients who are either in nursing homes or at home a lot, right? And their circadian rhythm's out of sync, or they have insomnia issues. One of the simple advice is get bright light. Sit literally next to the window, south-facing ideally, and let that light hit your eyeballs. Also, it's very important to have your patients wake up at the same time 7 days a week. Right? Well, doc, you don't understand. It's the weekend. I want to sleep till 9. Yeah, you can go to bed late, but you really want to maintain that circadian rhythm, right? That process S and process C to work to your advantage versus against you. So the talk wouldn't be complete without talking about blue light, right? So blue light is the most potent portion of the electromagnetic spectrum that affects our circadian rhythm. And also, it depends on when you're exposed to it, what duration, and time of day, right? And the intensity. I get a history from a patient, do you work on the computer? Yes, I do. What I've learned also is ask how many screens they have, right? I practice in Seattle, a lot of Amazonians and Microsofties in my practice, right? And you'd be surprised in terms of the number of screens. I had one patient tell me I have 3 screens, doc, and each are 27 inches. No wonder you have poor sleep, right? So again, everything's in the history and physical. I like this slide because it talks about the different spectrums from different light sources, right? So on the left here, the light source, the spectrum of the light emitted, and the amount of melatonin suppression. So on the top here is LED light bulbs, which is found in all of our electronics these days. Cell phones, laptop, TVs. And you can tell there's a huge spike in the blue light spectrum. Interestingly, incandescent light bulbs have been phased out over the years, and candlelight have no blue light whatsoever. So imagine if we were sitting here 100 years ago. In our households, we would have a lamp, maybe kerosene, candlelight, wood-burning stove. And maybe in parts of the country, because of Thomas Edison, you may have a little light bulb in your house. And yet in 100 years, we're exposed to all this light that I don't think our brains have evolved that quickly in the last 100 years to adapt to the light that we're being exposed to at night. Something to consider. So the question comes up quite commonly in my practice, do blue blocking glasses work? In theory, yes. Right? But really, if you look in the research, there's not a lot of good research in terms of high quality that says it's really useful for the general population. Also, if you think about it, I don't know about you guys, but when I pick up my cell phone, if there's a boring content, I'm moving on to the next item, right? So it's not just the light, but also the content people are engaged in affecting their sleep. This talk wouldn't be complete without talking about consumer electronic devices, right? These wearable devices that have exploded these last few years. The basic principles, right, is usually a wearable device on your wrist, and it's measuring heart rate variability and movement. And through algorithms, it's deducing the different stages of sleep. Interestingly, when these devices first came out, I have a lot of data geeks in my practice, so they wanted to verify the validity of their Fitbit or their iWatches. And so we actually ran sleep studies because they needed to have a sleep study done anyway. And we actually tried to correlate the data. Didn't match. So the EEG, which is the gold standard, was showing deep sleep, stage 3, but yet the Fitbit was showing some other stage of sleep. I do hope over time, and I think there's newer devices where they're actually putting devices on the scalp, which is going to yield more data, right? More accurate. They're non-prescription devices, but sometimes when you look at the printout, it looks pretty scientific, right? The fonts they put out is pretty impressive. It makes it look very valid or very scientific. But they're really not for clinical or research purposes just yet. And they're not FDA approved, so it doesn't meet that standard, right? This term was coined a few years ago, orthosomnia. It's a preoccupation or concern with the data from their devices. And they want to perfect the device, the data. Well, once you're asleep, right? You can't will yourself to give good data from the Fitbit. So I try to help my patients uncouple from these devices as it does become counterproductive, I think. So cognitive behavioral therapy is the gold standard for managing insomnia. But there's some precautions. Poorly controlled seizures, history of hypomanic or manic episodes due to sleep deprivation, acute change in health, excessive daytime sleepiness due to another sleep disorder, and certain occupations, right? An airline pilot, a truck driver. I think all of us are very familiar with sleep hygiene recommendations. They do help promote sleep, right? Keep a regular schedule, regular exercise, less stress, the bedroom for sleep and sex only. My wife always wants to remind me of this, that it's not an entertainment room, but the bedroom, winding down, and no electronics in the bedroom. One of the other things that comes up, sorry about that, is a patient will come in with insomnia symptoms, and I get a history. And I find out they got a 70-inch TV in their bedroom, and that's when their insomnia started. It could be simple as that. And reminding ourselves, back in the day, the TV used to be about this size, and it was in the living room, right? Sleep hygiene is important, don't get me wrong, but it's probably not enough to treat chronic insomnia, right? Just giving a handout for sleep hygiene is probably not going to give them the benefit that they need. And the reality is, after a 15-minute visit, you're running behind, you're on the way out, and they say, oh, by the way, I have insomnia for the last 3 months, right? How do you address that? And it's not easy. And I realize this talk can be challenging to implement in clinical practice. Cognitive behavioral therapy is more than just the sleep hygiene, and we're going to talk about that right now. So it's broken down into 5 components. Cognitive therapy, relaxation training, biofeedback, stimulus control, and sleep restriction. I'm going to focus most of the rest of the talk on the cognitive therapy part, okay? And you have this all in your slide deck. I did give you guys access to the slide deck. So that's why some of the slides have more content-heavy slides, because I want to be able to have you reference it after the talk. So cognitive therapy addresses the erroneous beliefs and unrealistic expectations that someone may have about sleep. Some of them include, I can't sleep without sleep aids, or I have a chemical imbalance causing me to sleep poorly. Or if I'm in bed, I might as well just rest. I mean, come on, it's better than nothing, right? So especially during the winter days, right? You don't want to leave their warm, comfy beds. Or as I alluded to earlier, they catastrophize their sleep loss. And for them, it's very real, right? We don't want to minimize it. They also have certain beliefs and expectations that are unrealistic. Sometimes, paradoxically, their concern about sleeping makes their sleep worse. Or they somehow will will themselves to sleep. The classic one is they spend on a clock that will display the time on the ceiling, right? Or let's maximize my time. If I'm awake, I might as well start processing and thinking about that work problem or my personal problem. Again, something we don't want to have them do. So cognitive therapy helps them challenge, identify, replace these thought patterns. And I'm going to talk about the top three there, the thought records, cognitive restructuring, and psychoeducation in a little bit more detail. Thought records. It's jotting down your thoughts as it relates to your sleep. Also, jot down supporting or refuting thoughts in terms of why you're thinking your way about your sleep. And also have them help look at their sleep in a more realistic way rather than in this cognitive distorted way that they've developed over the years or months. Cognitive restructuring is questioning the validity of their thoughts and beliefs about sleep, and to provide more accurate and adaptive ways about looking at their sleep. Just like I said, the last few nights I've had insomnia, I'm not going to make it a big thing. I'm like, it's normal, right? In psychoeducation, right, I like this little cartoon here of the brain working out, trying to retrain itself, which is not easy to do, right? And it's hard to do in a very short visit with a patient who has multiple medical problems. And relaxation training, right? Maybe some yoga, Tai Chi, but all of us are very busy. How do you fit that into your day? Biofeedback, I have to be honest, I don't use this as much in my practice. These are non-invasive techniques to get a sense of your physiologic state and what you can do to quiet that state. I kind of like this frog here, totally chillaxed here on the sofa, right? Sleep restriction is a concept that is very effective, but very hard to convince a patient to do. So let's say the patient goes to bed at 8 p.m., but they're not falling asleep till midnight. Well, they're just laying there for 4 hours. So what you want them to do is go to bed closer to the time they're actually falling asleep. So psychologically, the patient goes, well, why do I want to do that? I'm not sleeping already. I need to go to bed earlier. But as we talked about earlier regarding process S, the homeostatic sleep drive, if you do go to bed later, that drive is even deeper, causing you to fall asleep easier once your head hits the pillow. So this is a little formula you can use by having them go to bed later, and once their sleep efficiency improves, you can have them gradually go to bed earlier by 15-minute increments. A common question comes up, well, if I'm on sleep aids already, what if I incorporate the cognitive behavioral therapy with my sleep aid versus just doing cognitive behavioral therapy alone? And there really isn't good research to suggest that that combination works better. So when I got out of fellowship, I was a bit idealistic. I had every patient come off of their sleep aids before they did cognitive behavioral therapy. You can imagine that didn't go over very well. So I wised up over the years. I say, you can continue your sleep aid, but jump into the behavioral therapy as if you don't have the sleep aid there. What does that mean? What does that look like? So let's say you have a big presentation and you're worried about sleeping. Well, forget the behavioral stuff tonight. I'm just going to pop my pill and go to bed. Well, that's going to make the behavioral therapy very ineffective. So you can continue to take your sleep aid, but you need to lean into the behavioral therapy work as if the sleep aid is not there. And then once the behavioral therapy is fully embraced, then they can gradually wean off the sleep aid over time. And I think that works pretty well for most people. So some practice pointers. The American College of Physicians and the American Academy of Sleep Medicine recommend cognitive behavioral therapy as first-line treatment for chronic insomnia. The FDA approves a lot of medications, but usually they're for short-term use, and the sample sizes they're looking at is not very big. They're really not meant for long-term use. And I also realize that sometimes we inherit patients from other doctors who have been on sleep aids for many years. And again, that's a challenge. I like this concept of de-prescribing discussion. What does that look like? Well, whether it's Monday morning, you're seeing your first patient who's asking for a sleep aid for the first time, or someone who's been on it for years, you can have this conversation about setting expectations surrounding how long they'll be on the sleep aid, to set the expectation that it may not be forever, in a way that empowers you, the provider, the doctor, in terms of how long you're going to prescribe this medication. So let's go back to the case, right? The 30-year-old professor. She has both sleep maintenance and sleep onset insomnia. On exam, normal. She does have chronic insomnia based on definition, right? Over 3 months, and with daytime symptoms. She does go to bed early, but not falling asleep till midnight. She does have that late afternoon coffee, and she is on electronic devices before going off to bed. So some recommendations for her, right? Let's turn off those electronics 2 hours before desired bedtime. Now, you can imagine the response I get when I say this to my patients. Number one, I'm going to get bored. That's a good thing. Number two, what am I going to do with my time? Well, maybe read a book. Or, if people get into the chapters, which can be counterproductive, read magazine articles with a light source behind you. So no Kindle. And this is due to the blue light we talked about and also the content that she may be engaged in. Not go to bed earlier, right? We talked about that forbidden zone of sleep. Physiologically, you're going to be awake. There's no need to go to bed that early. Also, stop wearing that Fitbit, right? We want to avoid orthosomnia in her, where she's getting fixated on the data. Either wean or stop the medications and alcohol, right? And that's going to be a case-by-case discussion. Consider a notebook at the bedside, right? Jot down her thoughts about sleep, or if there's something worrying of her about next day at work, just jot it down. And also consider formal cognitive behavioral therapy for her. So in summary, insomnia is a very prevalent condition, which is multifaceted, right, in terms of the complexity of the insomnia. I really like the three-process model, right, in terms of looking at insomnia: precipitating factors, predispositions, and perpetuating factors. Sleep hygiene is for sure a part of cognitive behavioral therapy, but alone is not enough. And that de-prescribing conversation, I think, is worth having. Again, empowering you, the provider, to help that patient. So I've listed some references, okay, that hopefully will be helpful. The top one is accredited sleep centers across the country. And there's a bunch here in Oklahoma. And if you need a behavioral therapist, those would be good resources, reaching out to your local sleep doctor to see who they would use for their behavioral therapy. The second bullet point is sleep diary. So if you want to print out a sleep diary for your patient, you can use that website. The third is an online cognitive behavioral therapy, which I use for my patients in Alaska and rural parts of Washington State. And I think it's more acceptable since the pandemic to do something online. For a nominal fee, the patient can go through the whole CBTI process. And I've been using this website for the last decade or so. The last one is the University of Pennsylvania actually runs a program to teach all of you how to do cognitive behavioral therapy if you're interested in incorporating it into your practice, or a partner of yours or associate. In my practice, my PA does most of the cognitive behavioral therapy work, and she actually went through this program. Here's some books that I recommend. The third one, No More Sleepless Nights, is probably the one I use the most, partly because Dr. Howery did part of his work at Dartmouth. Dr. Jacobs at the bottom there started the website in the previous slide. And I've met with him before, and he's outstanding in terms of his knowledge, which has helped many people. So it's been an honor and a privilege to be with you this morning. If you have any questions, don't hesitate to email me. My soon-to-be 8-year-old daughter picked this email address for me, so hence I'm using it. So thank you.
Any questions for Dr. Chang?
Dr. Chang, explain more about how a blind person can still get visual stimulation from light. And is that certain types of blindness?
Yeah, great question.
Whether optic and trisected do they still get visual stimulation?
So that's a great question. The question is, if a blind person, how do they still perceive light? And I'll say that I'm not an ophthalmologist and I don't know the details, but yes, you kind of alluded to certain blindness, they may not be able to see, but this tract is still intact. But I don't know the anatomy well enough to say which blindness will lead to that. Certain blindness, and I think there's medications for those types of people who are blind, who their circadian rhythm's constantly changing, and obviously those individuals, that retinohypothalamic tract is severed, so therefore they don't perceive the light to the SCN, while other people who are blind are able to maintain a circadian rhythm despite their blindness. Yeah, great question. Yes?
Does antidiuretic hormone levels change with sleep at night? And if so, does age have an effect on that too?
Yeah, that's a good question. I believe so. I think as we age, people tend to use the bathroom more at night, right? But I don't know the exact link between the mechanism of that hormone and sleep. So, yeah, it's something that I have to look into. Yes?
I know you said you weren't really going to discuss medication.
Yes.
But would you be able to speak to the use of melatonin? Because it seems very prevalent, and there seems to be this idea that because it's a supplement, you can just use it as long as you want at any dose. And I see that a lot.
Yeah.
People are resistant to come off of it.
So the question is melatonin usage, and the challenge with melatonin, like a lot of these supplements, it's not FDA regulated, right? So what you see on the bottle, you don't know what's really in the product. If you really think about it, when we take melatonin or any sleep aid, we have to absorb it. It has to get into the bloodstream. It may be filtered out to a certain degree by the liver or kidney. Then it needs to cross the blood-brain barrier to do anything. And so is it really doing anything is the one question, right? In terms of milligrams, I think there's a whole host of milligrams out there. I usually recommend about 3 milligrams. I think there's 10 milligram tablets out there, right? I think hopefully with this talk you can kind of educate them, well, why don't you just have your normal brain secrete the melatonin that your body needs? But I also realize that changing behavior is very hard, right? In terms of harm, I don't think there is any harm. So taking the Hippocratic Oath, right? First do no harm. I think they're okay to take it. But the challenge is it really doing anything? And I would probably guess not really. Yeah, good question. Yes?
You had mentioned that, sometimes having a sleep hygiene handout could be counterproductive because it could put some blocks in there to doing what's really needed. But with the sample case, you did give her some sleep hygiene tips.
Yes.
What do you think?
Yeah. So you can imagine when you put a case up in a talk, it has to be somewhat simple, not too complex. For certain people, sleep hygiene may be just enough, right? And so that's where that individual assessment's going to come into play. What ends up happening is that for a lot of times, not all the time, but many times, you give the sleep hygiene, they come back to visit, they're still on their sleep aid, and they're still sleeping poorly. And now it's like, then they're like, oh, let me get another prescription for my sleep aid. And so hopefully through this talk, you're more empowered to say, well, maybe we need to go deeper regarding your sleep. Let's look at what are your beliefs about your sleep, right? And maybe if you don't have the time, you can refer to a cognitive therapist to delve into with the patient versus thinking, okay, as the provider, I'm stuck prescribing sleep aids because I've given them information, yet they're still needing the sleep aid. So, yeah, good point. Yes, in the back.
If someone seems to have a circadian rhythm that is out of sync with what our society expectations,
Yes.
can it be shifted?
Can it be shifted? Yes.
You just have to, yes?
So the question is, if someone has a circadian rhythm that's out of sync, can it be shifted? Yes, with an asterisk, okay? If they're genetically predisposed to be a night owl, where they're going to bed at 2 and getting up at 10, they've been doing this for 30 years, and they get a new job, and they have to be up at a certain time, you can shift that with them. And I've done this with patients. By 15-minute increments, every 2 to 3 days to go to bed early by 15 minutes and get up by 15 minutes earlier. The hard...
It shifts the rhythm, or are they just fighting against that?
Yeah, so you're literally a second ahead of me. So no, that's good. So you can shift them over weeks to, let's say, their desired bedtime, going to bed at 10 and getting up at 6, let's say. But on their first vacation, if they shift to 2 a.m. and getting up at 10 a.m., guess what? They have to reshift themselves because genetically they're already predisposed to that schedule, right? So you have to know their schedule from the history. If they've been doing this since college or since they were in high school, they're probably predisposed to having that schedule. To shifting them, you can do, but they need to maintain that schedule going forward. They can't stay up late a few nights. They're going to go back to that old circadian rhythm. Yeah. One of the other things I see quite a common is we live in a very aggressive corporate culture. So patients will want to be sending out the email at midnight to prove to their boss that they're working really hard. And then get up first thing in the morning at 5 to send another email out. And so that's also I'm seeing in my practice where people want to game the system. But I was told recently that you can actually time when the email goes out now. So I don't know how that's going to work, but it's a challenge. It's definitely a challenge. Oh, yes?
I know you mentioned Tai Chi and yoga, so physical activity prior to bedtime. Should you cut that off 2 hours before trying to go to bed? Physical activity.
Yeah, great question. So the question is physical activity, right? What if I do a jog right before bed? It's a bit of a dilemma because most of us can't fit physical activity in our day, right? And physical activity is really important. So if they can fit it in at the end of the day, let them do it. Having said that, you get the endorphins kicking in, which is part of the reason why we exercise. I took a walk around a lake yesterday after dinner. It was pretty humid out, and this is like at 7:30. But I wanted to get some fresh air and get my steps in. And so here in Oklahoma, the only time you can exercise, maybe if you want to get fresh air, is in the evening, right? And so it's going to be individualized. If they don't have any sleep problems, go for it, right? But if you have insomnia, you may want to maybe shift it and do it early in the morning, so before it gets too humid out, though. It was quite humid this morning when I got up, so. Yes?
So in the lay literature, there's lots of advice about what the optimal amount of sleep is. And so I'm sure your patients all have their own opinions about that. But from the expert, what's your opinion?
Great question, Sherry. So the question is, how many hours of sleep do you need? So interestingly, if we sat here going back to 100 years ago, we on average slept about 9 hours. Okay? Currently, what, 7.5? Easy. I mean, it's a wide range right now, 7 to 9. So what I tell my patients On your last vacation, where you didn't have a set schedule, so this is not going on a safari in Africa where you have to get up at ODOC 30, okay? But based on your own circadian rhythm, how many hours did you get? Right? That's probably what you need during the work week. And interestingly, the first thing you do when you come back from vacation is you sleep deprive yourself, right? And you're like, gosh, I really missed that vacation. I felt so good. It was because I was on the beach in Hawaii. Well, maybe it's because you got enough rest when you're on vacation. So what I tell my patients, when you come back from vacation, don't truncate your sleep immediately, which is what most of us do. Pay attention to what your body needs. And usually on vacation or on a long weekend, that's what your body needs typically. Yeah, great question, Sherry. Thank you. Any other questions? Yes, please.
Do you work with children or treat children with insomnia? And if you do, what are some different techniques you may use with children versus adults?
Yeah. So the question is regarding children and insomnia. And that's all. I don't treat children typically, but in my training I did have pediatric work done. One of the challenges is that children are not getting enough sleep. Okay? Children need much more sleep than you and I. And in part, it's due to school start times. So in Seattle, they pushed high school time to the last opening time slot. I actually spoke to city council because teenagers like to go to bed late and get up late, right? They're genetically predisposed to having a delayed circadian rhythm. So why are you having high schoolers start at 7 o'clock in the morning? You're going to sleep, they're asleep the first 2 periods anyway. So hopefully through different education and paying attention to the circadian rhythm of children, right, especially high schoolers, having them go to bed late, get up late, have a school start time that is consistent with their circadian rhythm. The other challenge is electronics for children, right? They're stimulated just like you and I, and going back to the 70s and 80s with the rabbit years, right? We didn't have much options back then. But now children, I mean, there's innumerable things they can engage in. And also, sleep deprivation can lead to ADD and ADHD symptoms. Whoa, right? And what do we give children who are hyper? Why? Because when you wake up the brain, it calms down. So if we go back, if you give a child enough rest and they're waking up refreshed, they're going to be calm. Right? So something to think about. Great question. A little bit off tangent from the talk. Yes?
If you do have periodic movement
Yes.
disorder, what is a good way to treat it?
Yeah.
Is there anything non-pharmacological?
Well, you can check a ferritin level. You want it greater than 75 micrograms per milliliter. Even though if you look at the range, like low is like 30 something, so you have to pay attention. So you have to have it above a certain level. That could help. You can definitely avoid certain medications, and unfortunately a lot of medications can lead to more restlessness in the legs. So restless legs is a clinical diagnosis. Periodic limb movement disorder is based on a sleep study. But as you are alluding to, restlessness in legs can lead to PLMs at night, fragmenting the sleep. Yeah. Yes, in the back.
Are the blue light blockers on our devices effective?
Yeah. As you can tell in my talk, I was being diplomatic, right, in terms of what I was saying. Clearly, the industry has a high incentive for you to engage in your electronics all the time, right? So I think we have to use good judgment, right? And again, it's not just the light, it's the content. So do a trial. Have your patient do a trial, right? Let's do an experiment. No electronics for 2 weeks. Or for yourself if you're having sleep problems, right? I'll be honest, my cell phone's right next to me on my nightstand, and if I wake up in the middle of the night, I'm looking at it, right? So even though I'm giving this talk, realistically, it's very hard. I'm connected to the device. Interesting, last night I woke up and I couldn't fall asleep. I didn't look at my cell phone, and I fell back to sleep pretty quickly. So, thank you so much. And I'll be in the panel discussion. I'll be around, so if you have any questions, feel free to ask.